we've heard from some very interesting programs and had some stimulating discussion, both about what's going on in the US and what's going on in a few places around the world, although the world is very big. And this is the moment to say, what does it all mean? And how can we move this stimulating discussion ahead? We are fortunate to have on this panel not only the chairs of the first two previous panels, Krishna and Mark, but joining us from the World Bank, Dr. Agnes Saukat, who has a very impressive title. She is Global Solutions Leader for Service Delivery at the World Bank. How impressive is that? And Agnes has been recently the Director of Human Development for the African Development Bank, where she was responsible for health, education, and social protection for 53 countries in Africa. She served as lead economist and advisor on human development for Africa at the World Bank. And she's both an MD and has a master's in nutrition and a master's in public health and a PhD in health economics. I don't know how you did all that. But we've asked her to lead off and to start by saying what the World Bank hopes to do as they survey the whole world in improving delivery of health care, and how does that relate to disruptive innovations in diabetes.
Thank you, and thanks for the very kind and generous introductions. Global Solution Leader is a very funny title, and slightly ambitious. But in a nutshell, the bank, as you've heard, has been reorganizing, and part of this reorganization is shifting its focus towards poverty reduction, shared prosperities, as well as global public goods. And that, as part of that, certainly the focus on human development and service delivery to the poor and for the poor is a renewed focus for us. And that's the reason you have these new approaches and these new positions like mine, which have been created to try to see how we can create a community of practice that brings together the knowledge we have about what has been working, what is working in serving the poor, and what will be the challenges for tomorrow in terms of service delivery, and particularly service delivery for the poor. And certainly today the bank major commitment in terms of commitments to international goals is the universal health coverage. And as part of that, we really see some major challenges in the service delivery area across all countries. And what is fascinating for me, listening to the speakers, which were fascinating this morning, talking about such different contexts as the US and India and Spain, is the commonality of the issues. We're really now one community, and it's increasingly difficult really to separate the issues between low income, middle income, and OECD countries. And one of the reasons is really that all countries are now going through a demographic transition, an epidemiological transition. We have health systems that were designed to respond to a lot of maternal and child health and communicable disease, and they have to evolve. And even in low-income countries now, many countries face twin type of epidemics in which you see both still the unfinished agenda of uncommunicable disease, that's the case in India, as well as an emerging agenda of communicable disease. And in a way, it's even more of a challenge for those countries because they already have to tackle the demographic and epidemiological transition while they're still struggling with actually building. So in this area, the bank is working very much on three main areas, I would say. Certainly, health financing, and we talked a lot this morning about provider payments and financial incentives, and this is an area in which we have a lot of experience, and we particularly have focused over the past few years on a particular modality of financing, which is results-based financing, financing for results, or performance-based financing. There are a lot of ways we can look at that, performance-based payments, results-based payments, which is a movement right now that is happening about everywhere and is still expanding. The second area is labor markets, and I'll come back to that later when we get into the body of the discussion. But this is really an area that we see is most critical. There is today a large deficiency in terms of numbers and shortage in most of the countries. You were talking India, missing 800,000 doctors. In Africa, it's estimated today that there are probably just today 1 to 2 million jobs that are unfilled because of lack of skills. So people actually pay for healthcare that is provided by unskilled providers because just that there are no skills. And the third area is innovation and new models of service delivery. So it was very interesting to listen today about how do countries tackle this issue of the epidemiological transition, how do they tackle the issue of institutional changes, of changes in the labor market, and how they develop models that actually ultimately do serve the poor and the most vulnerable, including those affected by chronic disease.
Thank you very much. How does the World Bank actually operate to move those objectives forward? I mean, what do? You've got a huge world to look at, and what's the most, how do you effectuate these kinds of things?
Well, I'm not sure we are terribly effective. I think we've been, certainly it's very controversial. You can just Google World Bank and get all these debates. But I would say that the bank works through basically three modalities, and the one that is most known is the financing, but in a way it may not be the most important. It actually works first and foremost by working on diagnostics, and we're trying to really serve our clients by what we attempt to be, that is a knowledge bank, and using the fact that we are global and we work in Latvia as much as in Central African Republic and in India, to be able to cross-fertilize and sort of bring all these experiences together and try to distillate some key lessons learned. And that's part of what I'm doing, that's part of my role today in the bank, is to try to enhance that role, because we see as in fact financing needs in a way are declining because most countries are getting richer. Most countries don't need grants anymore because they have access to financial markets. So our financing role probably relatively becomes less, while our knowledge roles becomes more. And in between the knowledge and the financing, there is the whole area that we've been discussing this morning of policy and policy dialogue and policy development, where we also try to build this expertise, building on our core diagnostic, building on the knowledge we're trying to create. We need to create primary type of data and information, but also to bring new perspectives on the way to analyze these and do cross-country comparisons. And then have this kind of policy dialogue at country level. Right now in India, the government of India is developing a new health policy. So they, for example, have asked us to provide our views. Not that we are designing this policy, not that we are in any way be a major stakeholder, but sort of asking us, what is your view from a global perspective? What is your view from what you understand from an outside viewer's perspective on how India fares in terms of healthcare? And definitively, that's that combination about understanding the country. We have offices in countries, we have health experts in countries, as well as bringing the sort of outside perspective and try to enrich that policy dialogue is really one of our goals.
As I listened to the two previous panels, I heard several themes, and one of them was getting the information. Clearly, if you want to improve care, you've got to know who's at risk and who isn't, and the potential is enormous with the new types of information technology. On the other hand, we also heard these EHRs don't talk to each other. We have to do all sorts of workarounds to get this information. Is there, I wanted to ask both Krishna and Mark, did you hear themes that could across the international divides be models, or how would you move forward on this information problem?
I can start, and we heard from the first panel this morning, but also from a lot of the work we do in working with dozens of similar innovators around the world, that clearly at many levels, this idea of data, access to data, and sharing of data and information becomes critical to success. Right? It starts from a policy and the perspective of global institutions like the World Bank, and being able to, as we just heard, become a conduit for understanding and sharing knowledge is very important. And part of the rationale for creating a new organization like IPIHD for us was the understanding that there was a lack of platforms for sharing of knowledge and data about what works and what doesn't work. So we have entrepreneurs who are trying to address the same challenges in diabetes in India, in Mexico, in Spain, and they're not talking to each other. They're not learning from the shared challenges and the approaches that may work and are shared. So as the world converges, we need platforms that can actually inform, be able to distill insights and share them. I think secondly, one of the key themes that we saw across all the organizations today, but also more broadly, is that those organizations that are committed to actually real deep understanding in terms of gathering data, having metrics, and measuring performance are those that are more flexible, that are more agile in meeting the needs of their customers, their patients, and their markets.
Just to add to that, I think as Anya said, knowledge is one of those key areas of value creation for collaborations, not only within a country where, as you've heard today, there are lots of opportunities for accountable care organizations and healthcare providers to learn from each other as they're moving into new ways of delivering care, but worldwide. And you all have an extensive network to support that at World Bank. The IPIHD initiative that Krishna is leading is sharing experiences across innovators. And what we're trying to create with these case studies and the additional set of resources around how to adopt disruptive innovations and how to make those sustainable is really part of that same overall theme. And I think, Alice, your question also got to the fact that for changing this model of care delivery for diabetes, there has to be new kinds of data sharing at the person level, not
yes,
just.
I'm thinking about real patient level or per.
Yeah, and we heard, I think that was an absolutely consistent theme among every single one of these countries and every single one of these innovators. What was interesting to me is the different levels or stages or approaches to going about it. So we heard about some very advanced systems. Ribera Salud has been at this for quite a while, and under a long-term capitated at-risk model has really faced some financial pressure and had the resources available, the flexibility in how to spend resources to develop. I think you were talking about hundreds of data elements that you track longitudinally on patients, and heard a little bit about this from Chuck as well on how they've tried to develop at Aetna some longitudinal patient data systems. But what I was also impressed with was that you don't have to get that comprehensive. And in fact, you can get distracted by spending too much money on information systems that don't really do what you want to do. I heard from Jose about how electronic health records are nice, and I'm sure you appreciate the subsidies that you got to install them, but what were they? They're computerized note entry and not really creating that longitudinal picture that can be shared across the different members of a care team. So at relatively low cost in the Rio Grande ACO, they basically got their smart IT guys to put on top of it. It's not, not all data, but certainly the critical information you need for a diabetes checklist, and to identify and make sure every provider involved knows if their patient is not being managed to effective outcomes. That's a much cheaper, faster solution that can be implemented and can start having effects in the short term. And even lower cost in India, where in these rural providers, there are no electronic health records. So you have a cloud-based approach to gather data from cell phones that people are using out in the field. Not high-tech, not expensive, but clearly an approach that's able to make an impact on care delivery and change the way that diabetic patients are managed in the short term.
But suppose I've just been appointed health minister in some country in some part of the world, and I want to do something about chronic care and diabetes. Where do I go to find out what's working? I might have tuned into this panel, but...
Yep, that'd be a good start.
Does the World Bank have a role in this, or where do I go?
No, I think that's one possibility, among others. I think certainly, typically, ministries of health would turn to the WHO and to the World Bank and other organizations, but also to different academic institutions who have been working on this. What we're trying to do as an international organization is, when a country comes to us with this kind of question, is really to bring. We not necessarily have the knowledge in-house. We sometimes do, but of course, very often we don't. And then we really try to find, throughout our network and our communities of practice, those good examples or those people who have the knowledge, or those institutions who have the knowledge, and bring it to the country. And that's why we really do a lot of cross-country exchanges and fertilization, and when we have this kind of question. Right now, we get a lot of this, particularly post-Ebola. We get a lot of questions about how you build a health system in a country which has close to nothing. We get a lot of questions about, of course, universal coverage and health financing and models of delivery for the poor. And within that, I would say, maybe very in a very simplified way, that I think there are really three issues that we, in this particular area, that we try to highlight. The first one, I think we discussed it a lot this morning, is really the financial incentives and the financing modalities, particularly the payment, the provider payment facility, mechanism. And clearly, this is essential. This is high-power incentive. It's about money. The whole health economics literature is about that, about supply-driven demand, about how fee-for-service leads to escalating cost and providing more services. It's also about asymmetry of information, how patients cannot really judge the quality of care, how they get care, not at the right time, not from the right provider, and so on. So that's really very essential. And I think what we've learned there was mentioned this morning is, and I think that's the trend today, that somewhere a combination of capitation payment and some kind of contract where you have some level of performance-based financing is sort of the way to go. This is actually where most countries are going towards. Most OECD countries are thinking about that kind of combination, this sort of capitation, so that you have this global payment that brings together the curative and the preventive and the promotive, as well as some kind of link between the money and the performance, the results. You don't want your money not to buy anything, so you're really trying to get those indicators. And you see, most of Europe now has payments actually for diabetes, for providers, payment for performance that are based on lab tests, on sort of hard indicators. But what I want to say there is, yes, it is terribly important, but this is not, unfortunately, we would want it to be, but it's not the panacea. And that's maybe the qualification I wanted to give to this morning's debate is there are actually countries who don't have capitation payment and are doing very well on diabetes care. And that's actually my country, France, has actually quite good outcomes and is still having a system of fee-for-service. So it's not all about payment, although it is a lot about payment. And that brings me to the two other aspects, which is probably where France gets it right, but it's not the only country to get it right, is it's also about the providers. It's about the providers' organization. It's about the professionalism and altruism of the provider organizations. Do we have provider organizations that are just motivated by profit? Or do we have provider organizations, as you say, which are more in the social enterprise, social business, that actually have a level of ethics, a level of motivation that is different, that is about the ultimate well-being of the patient? And that matters a lot. And that's terribly important in middle-income countries and countries in transition, because they usually come from a public service which is not performing that well, as we know in India, and is still very much focused on the old types of problems, doesn't really know how to deal with chronic disease. And an emerging private sector, totally unregulated, totally into conflict of interest between making more money and the interest of the patient. And there's really something very important that needs to happen with the emergence of a sector that is actually a professional sector, whether it comes through not-for-profit organization like it happened in Western Europe and North America, or social enterprises, or some kind of better regulated, more ethical, for-profit type of services. I'm not making any choices there. I think what is important ultimately is that you have professional norms, regulations, ethics, and that's a major issue in many, many countries.
If I could just add to this I think professional norms are absolutely critical worldwide, in the United States and other countries too. What hopefully some of the payment reforms can help do is create more alignment with between what patients want, what providers would like to give them, and the way that providers are reimbursed. And I think there are a lot of examples, not only the ones today, but the Commonwealth Fund, our support from the Merkin Foundation have helped us highlight some ways in which professional norms and really the goals or rewards for people who are going into the healthcare profession can be better supported by these innovations in care.
And isn't there a role in between professional norms and monetary rewards? Somebody said earlier this morning, doctors are very competitive. They want to know what they're doing and how well they're doing for their patients, and it's not often obvious.
It is. So, 2 points. Let me come back to the doctors, but I think part of what's also missing when we talk about professionalism in a sector is actually defining what those professionals are. Right? I think we're stuck in this model in many parts of the world where doctors are at this high end of this hierarchy, and then you've got nurses, and there's almost nothing else. And we know that we will never train enough doctors and nurses to care for the people around the world and the health problems. And so
Should we?
Exactly, right? So that will also bankrupt us along the way. So actually defining and moving toward a competency-based model of creating a professional health workforce, I think has to be on the agenda all over the world, including in the US. And we've moved toward that with some advanced practice providers and other steps along the way, and professionalism even of community health workers. And so to be able to define that, I agree with. And I think for all of those professionals, this idea of accountability and probably accountability as teams is going to be important, moving away from the current type of provider benchmarking that's very much at an individual level, which gets to this idea that somehow the individual has a direct consequence on outcomes, to being responsible and accountable as a team for the health of populations and other economic outcomes is really, I think, what's needed, which gets us back to this idea of we actually have to have something to measure if we're going to benchmark people.
And that is where, as you heard from Ricardo, where Mexico is taking some steps to try to promote these new approaches to care, and whether you call it the competitiveness among doctors to do the best, or among
providers
among local areas or regions to not be at the bottom. Transparency is absolutely critical foundation for that, and one of the advantages of working on diabetes is that it is a condition where the measures of outcomes are relatively well defined. It's very hard to capture everything that matters to each patient about whatever their conditions might be, but in this case, we have good short-term predictors of long-term complications. We have very good evidence-based measures of screening and behavior change and medication treatments that are clearly responsible for improvements in outcomes. So as for countries that are moving down this road, or for health ministers that are moving down this road, diabetes is not a bad place to start.
We want to go to audience questions in just a minute, but let me raise one more theme that came out this morning, and that's long run versus short run. The prevention, where you're really working with people who don't know they're sick yet, and you can have long run benefits from that, versus working with people who are already very sick and are absorbing a lot of your resources. Any lessons there that might go across the international boundaries?
Sure, I think it's all of the above, right? I think we can't ignore the 350 million people around the world with diabetes and say we're going to focus just on prevention, right? So there's a critical short-term, intermediate, and likely long-term need to provide acute care services. But if we focus just on that and not think about the public health and population health measures, we're going to just get further and further behind, because we know that the rates are going to continue to increase. So I think the challenge is really at a system level: how do you combine public health, population health, and acute care services in some rational structure that then is tied to the availability of public and private sector resources? I don't know that anybody's really gotten this right.
You don't have the answer?
Well, in the United States, there's so many concerns about the level and the historic rate of increase in costs that most of these reforms are being implemented with an emphasis on getting costs down in the short term. So that's why a lot of these models have started with shared savings, as you heard about from both panels. Some of the fastest ways to get savings in the short term are to focus on very high-risk patients who are clearly, can be relatively easily identified, and there's some relatively well-defined steps that work once you get out of the traditional model of just treating complications after they happen. The payoff in terms of better health outcomes and maybe lower healthcare costs for people who are earlier on in the process is much longer term. And I think you heard some comments earlier today around how a subscription model or something that's further away from fee-for-service can help put an emphasis on innovations that engage people more effectively earlier in making their own behavioral changes and doing things that frankly are going to be more outside of the healthcare system. But clearly that's an area where more work is needed.
Let's invite audience questions. Have microphones available, and yes, here is one. Tell us who you are and state a short question.
So Pamela Anderson, I'm from Johnson & Johnson in marketing and new product development. One of the things that I used to always ask my teams was, if there was one thing I could do for you at the end of a visit, what would that be? And I guess I'm curious, because diabetes is so highly complex. I've heard about cost, ethics, and you can go round and round. What would that one thing be that the team would say that could be done in the short, possibly even long term?
You want to start on that?
Yeah, I don't know that I'm going to come out in favor of one, because we heard about so many today, and it really depends on the perspective or the place where you want to make a difference. I think what is impressive from what we've heard about today is that there are a number of steps that can be implemented in the short term and have an impact. I mean, they do have some upfront costs, whether it's making these basic steps to collect person-level data so that you can identify gaps in quality of care and addressable risk factors like elevated hemoglobin A1C, or whether it's a shift towards a team-based approach to care or kind of earlier outreach to patients. These steps can make a difference, and I don't know that there's any one magic bullet. I think what the innovators we've heard from today have emphasized is that, yeah, you do have to recognize that this is a chronic disease that's multifactorial, and there are many ways to influence that depend a lot on the individual patient and the circumstances, the ecosystem, as Krishna was talking about earlier. And what's really changing is that the focus is on finding that right combination of innovations for each individual patient.
Yeah, I think it's really hard to say there's one thing. I think what we saw is that every system is approaching this and what's most important to them in their local context, and a lot of what's missing is how we integrate or bundle a lot of these point innovations into creating a system of care that becomes more rational over time. And if I had to prioritize one theme, I think it's really about empowering our patients and consumers, really, to be more aware, to be more health literate, but to also be more accountable for decision-making, behavior modification, and being co-producers of health as opposed to passive recipients of healthcare services over time. And I think that eventually is what's going to cut across everything from prevention to treatment.
I would actually take the risk of giving you one
You have
thing.
one?
All right.
Good for you.
All right.
And I would say that actually I find diabetes being a fantastic tracer of effectiveness of health system when it comes to how the health system handles chronic disease challenges of tomorrow. And it's exactly because there is actually this quite simple blood test that allows you to measure the effectiveness of care. And it's being used right now by several OECD countries, and even middle-income countries now are starting to. One of the things that we've been trying to promote at the bank is really integrating vignette measurements of quality systematically in what we call service delivery indicator surveys. So we're trying to promote in most of the countries, and we actually have increasing demand for that, facility surveys that are independent and that actually measure quality of care. We already did it in a few countries. I'm telling you, this is quite disheartening. And we started with simple things like antenatal care and assisted deliveries and treatment of malaria in Africa. And now we're trying to expand, and we found that actually the management of diabetes being a fantastic tracer and indicator. And one thing that I would say, one thing we could try as a community to promote that this is actually measured in every country on a representative scale, that we would have some sample of facilities that would allow you to actually know how the country is doing on this management and reflect on what it says about how your health system works.
This is why Agnes is in charge of global solutions.
That's why.
You have another question?
Robert Ratner from the American Diabetes Association. Over the last 30 years, we've actually gotten very good at reducing chronic complications. Cardiovascular disease is down by 60%. Amputations is down by over 40%. The problem is that the costs of diabetes care are going up because of the number of people developing diabetes. The per capita expenses haven't really changed in the last 5 years. So the issue that Dr. Rivlin brought up in terms of prevention becomes critical. What we're seeing is a growth in diabetes, in particular in countries that are advancing quickly. India, China, Indonesia, these become real problems. I haven't heard anything about disruptive innovation in terms of public health, in terms of really going into a societal basis for preventing diabetes. And I'd love to hear the panel's impressions.
Good question.
First, I'd say you're right, but I think the comment is very much from a U.S. or developed economy perspective. Right? I don't think that we've become very good around the world at preventing complications of diabetes. right? If you go into the Narayana Health Hospital in Bangalore and see the hundreds of heart surgeries they're doing every day, it's because people aren't being managed. And so I think there is the need for capacity development and disruptive innovation up and down the value chain of diabetes prevention and management and avoidance of complications. And a lot of the innovations we're seeing, to earlier comments, that the short-term payoff is looking at a high-risk population and being able to reduce cost or increase effectiveness of therapies. And I think that's where we're seeing a lot, especially in private sector innovation. I don't know what the incentives are, especially to drive private sector innovation, which is where we focus and where we actually see a lot of the disruption coming from when you get to the prevention and public health measures, right? I think we're starting to see it in places like energy and places like water, and which we know, lead directly to health outcomes. But in terms of behavior modification, I think I don't think we're where we need to be yet.
And that ought to be part of, when you're talking about diabetes indicators, you're not just talking about how well controlled the diabetics are in terms of hemoglobin A1C, but in terms of risk factors and progression to prediabetes and diabetes. And it hopefully is going to become more of a prominent part of health innovation. But I think you're right that we haven't seen as much action there yet. It's been more downstream, hopefully moving upstream.
But it is the private sector that controls the sugar in the drinks and the volume of food and the quality of fast food and all of those things. And
well, again, here I'll take a risk to give you a clear answer. I mean, I was a commissioner of the Lancet Commission on Investing in Health, chaired by Larry Summers and Dean Jamison. We actually recommended in this commission a tax on sugar. And this is something that is being discussed. It's not a World Bank recommendation, but I think it should be on the table, as well as very frank conversations about the balance between what we were discussing, provider payments for diabetes, and actually what is actually always the problem is that we pay for illness, we don't pay for health. So how you develop a payment system that actually pay for health and for actually reducing the number of people who develop diabetes, rather than a payment system that rewards people for taking good care of people who have.
So if I may just have a very quick follow-up, I think you can look at diabetes very much the same way you look at infectious disease. Antibiotics are wonderful, but the most important change to prevent infectious disease was sanitation and clean water.
we have run out of time. We could have one more question, perhaps. Yes, Gina.
I'm Zina from Sugawar Healthcare in India. I think this panel is really well constructed because it really brings together all the learning since morning. What I really see on the panel is the convening power, whether it's Brookings or IPIHT or World Bank, and your emphasis on labor. What I realize, or what I feel, and maybe that is just my limited understanding of the sector, is when we talk about health, and when we talk about ministries, it is kind of truncated at Ministry of Health and Family Welfare. And then we talk about, the service sectors within that. But if you're talking about diabetes being the indicator for how the country is doing on health, why wouldn't the conveners bring on the table, people from Ministry of Finance, Ministry of Labor, all of that? Because very honestly, if you do well on health, all the other ministries benefit, which are not currently relevant stakeholders, and they don't have an opinion in how policy is being shaped. And I see all of you playing a very important role there. And do you see that happening anywhere in the world? Or because I can only speak on behalf of India, or from whatever I understand of India. Thank you.
Yeah, well on this, first, I very much agree with you. I think it's exactly what is happening, and I actually this is a great suggestion which I'm going to follow up on. Is which actually to get this idea of using diabetes as a central question with ministries of finance. And here I have an interesting experience to share. As African Development Bank and World Bank worked with Harvard University School of Public Health in developing a leadership course for ministers of finance on health. And believe me, that's not easy to get ministers of finance to accept to sit for 3 days talking about health. And it's only the convening power of actually, Harvard and Larry Summers and the bank that managed to we got over 2 years, we got 20 ministers of finance and then some very prestigious names. And it's very interesting when they come, the first thing when you ask them about their expectations is, how are we going to spend 3 days on health? What is it going to tell us that we don't know? I mean, after half a day, that should be done. And on the third day, they are just full of excitement, and what they're saying is, why were we not told that earlier? Why was it hidden from us? And the key story there that they think was hidden from them is the efficiency story. The fact that they are incredibly, that there are such low-hanging fruits. And there are such effective interventions in health. It's actually one of the sectors where we have, the most evidence about, hardcore cost effectiveness, cost benefits. And when you show them that, and you show the low cost and the benefits, and actually how this is actually very easily, you can actually very easily translate it into programs and service delivery and actually serving the people, which is ultimately they are politicians, so this is what they want. You see really that it becomes an eye-opener, and then we had a very interesting feedback from ministers of health after that saying, what did you do to them? They came back and they were completely changed. And I think that the problem was that typically when we speak to the financier, we always come to them for asking for more money, but not actually conveying the message of efficiency. And in fact, these are very smart people. They can understand it. They can, and one of the things that, for example, Larry Summers was saying that he was always puzzled when we were working on the commission and when he was working in the US government, he said that he would move from one meeting where the big issue was the escalating cost of health to another meeting which was about jobs and employment and how vibrant the healthcare industry was. So this kind of issues are really something that we can discuss with the financier. And on the labor market, you were mentioning, yes, certainly we could think that probably there is an unlimited demand for healthcare, but clearly in many countries, when it comes to the labor market, we currently have a supply problem. That there is demand, there is money to pay for health workers, but you just have constraints on supply, and then, I mean, this is a whole other debate as to why. And then I'm not going to get into the whole political economy of the, of the medical community.
We are seeing innovations there, too, in terms of labor supply, and we heard about them in the team-based approaches now, and I think there's certainly a lot of potential for people with less training than 4 years of college and 4 or 5 more years of graduate school to have a big impact on improving outcomes for conditions like diabetes at a much lower cost, and giving them a chance for more productive wage growth than they'd have with their existing career opportunities. So maybe Larry, we can get those meetings that are integrated for Larry.
Well, we're going to have to close this event because we have run out of time, but it's a very positive note to close on. And I, for one, hope that we can have something in further communication that comes out of this meeting today that will push these ideas forward around the world.
And there will be more to come on this.
And there will be more to come. Mark, do you have closing
just to add to that point, you all have seen the case studies, you heard the perspectives from around the world today. Clearly, there are similar problems being faced in all countries, developed and less developed. Clearly, there are globally relevant innovations in care taking place and globally relevant lessons for policymakers that should be considered to accelerate this progress. We've really appreciated the opportunity to have the support from the Commonwealth Fund to be a piece of their efforts on trying to promote better care and greater efficiency worldwide, as well as the Merkin Initiative, which is all about bringing some of these new perspectives to clinicians who may not have typically thought in these ways about prevention and things that they can do and actually take on accountability for getting to better outcomes for conditions like diabetes. So more to come. I'd like to also give a thanks especially to our staff here at Brookings that made this possible: Andrea Toomey, Kate Samuels, Maggie Darling, Lizzie Drobnik, Monica Mayday, Joanna Klatzman, Michelle Shaljian, and Elise Presser, and we're still on time, right, Elise?
Almost.
Thank you all, and
Thank you
especially
all.
thank you all very much for coming, and look forward to continuing to work with you. Thank you.